Thank you, Dr. Namrata. We just heard an excellent presentation by Dr. Yokoi,
Yeah.
talking about a new way of looking at fluorescein staining. I'm going to talk about the more traditional concepts that we have been using regarding fluorescein staining and some of its nuances. When you're looking at any subject or problem, one of the ways that has been described to understand it better is to ask these questions, which are described as the 5 Ws and the 2 Hs. We can use this concept when we are looking at the assessment of the ocular surface health using stains, and that is what I will be talking about, the dynamics. If we look at the first question, which is the why, we have to ask ourselves, why do we need to stain the ocular surface? We just heard about the use of fluorescein staining, the negative part of it from Professor Yokoi. So we use the fluorescein, and based on where it does not stain, we try and understand the impact on the ocular surface. I'm going to be talking about the positive fluorescein staining. So what do we do when we actually see fluorescein staining the ocular surface, and how do we assess its impact? So the reasons for staining would be to detect the presence of ocular surface changes, use these changes that we detect to diagnose different types of ocular surface disease, document its extent, and use this documentation to help prognosticate the disease when we talk to the patient. And after we start treatment, follow up the surface to see whether it's getting better or worse using these very same changes. Who are the major players as far as this sequence is concerned? All of us are familiar with these three stains that we use. The most recent entrant is Lissamine green in 1973. And no talk on ocular surface staining would be complete without mentioning the work of Non, who worked extensively studying the interaction of all of these three dyes with the ocular surface and published a series of articles from 62 to 85. So we understand that we can use fluorescein for the cornea, and we have traditionally used rose bengal and lissamine for the conjunctiva. Although rose bengal was the first entrant, recently, because of its irritating properties, its cellular toxicity, and the reason why that it photosensitizes the cells, there has been a trend to move away from it and more towards lissamine green, which has all of the good properties of rose bengal without the side effects. Also, when you're looking at staining of the conjunctiva on an angry red background, the green stain shows up better than the red stain itself. All of these dyes can be used as strips or solutions, and the concentrations are given here. The solutions are generally better because we can put graded amounts, predictability on the ocular surface. But if you're going to use it in the clinic, make sure that you have the minims, which at the moment we don't in India, because if you keep a bottle of these, it gets contaminated very easily with Pseudomonas, and we all know what can happen after that. So what is it that we actually are seeing when we put these dyes on the surface? So what I've done is basically I've shown you the epithelial surface, I've shown you the epithelium in cross section, and this is an ultrastructural study. The reason why the normal surface does not stain is because of these healthy epithelial cells on the surface. The fact that they are bound to each other by tight junctions, which are impervious to anything but the smallest molecular weight solutes, and the surface contains microvilli, which absorbs the mucin, the membrane associated mucins, and together they form the glycocalyx. And when these three are present, the stain does not take up on the surface. If for some reason there is damage and the stain gets through to the deeper layers of the corneal epithelium, there are gap junctions between these deeper corneal epithelial cells, and the dye can then diffuse. So the epithelium of the cornea is a semi-permeable layer for fluids and only for the smallest molecular weight solutes. So when we actually see staining, we use the term superficial punctate keratitis. What happens here is that there can be a loss of the tight junctions between the epithelium, a loss of the glycocalyx, or individual cell death. And this results in this fine stippling that we see because of the surface events that are happening on the corneal epithelium. The next step after this is what we call punctate epithelial erosions. It is just the same pathology, but of an increasing degree. There is more cell death and more layers of the six-layered corneal epithelium are lost. So you get little craters where there can be pooling of the dye, and this results in the coarser pattern of staining that we see. We can also see this coarser pattern of staining when there is epithelial multiplication and heaping, which we typically see in adenoviral or microsporidial keratitis. And here, the way to distinguish it would be to make a slit. And in this, because of the elevation, this plot of staining would be an elevated convex structure, whereas in the previous instance, it would be a depressed concave structure. Of course, after this, if the disease progresses, there is a loss of all the cell layers of the corneal epithelium, and then you get a total epithelial defect. So here it's not just the area of the epithelium, but the fact that all layers are lost, which is typical of this. And whenever you see a defect, we also want to pay attention to the surrounding epithelium. You can see the breakup here. You can see the shattered light reflex of the slit lamp light here, all of which indicates that this is an unhealthy epithelium. And if you look at the margins of the defect, they are convex outwards, meaning that there is no attempt at healing. The edges are heaped up. So this is a typical non-healing or a persistent epithelial defect. So when do we use these dyes? Basically, you do this to look at ocular surface health loss when you have a dryness and there is damage to the cells. You can use it to stain the tear meniscus to measure its height more better. You can use it in a fluorescein clearance test to look at the evacuation of the excretion of the dye from the surface. You can use it in limbal burns from alkalis and so on. So you can look at the limbal stem cell damage, and you can use it on the corneal surface to look at the various infections that we see. We can also use it to look at leaks, either from blebs or from corneal injuries. From the assessing the effect of contact lens use on the cornea, you can see the 3 and 9 o'clock staining here. And in LASIK, if you see an epithelial ingrowth and when you stain the surface, if you see a spot of staining here at the edge of the flap, it means that the cells inside in the interface have a communication with the outside, and this is an indication for surgical removal of this ingrowth. Again, in LASIK, if you see this pattern of positive and negative staining, this indicates LASIK flap folds, which are full thickness events, and this helps you differentiate them from striae in the flap, which are within the substance of the flap, wherein you will not see this positive and negative staining. You can also use these dyes to stain the surface of ocular surface tumors. How much of this dye do we use? Again, Professor Yokoi mentioned it. For fluorescein, we want a very small amount of 1 to 2 microliters. You can be more generous with the other two and use about 25 to 30 microliters. I'll explain why in the next slide. It's also important to pay attention to the diluent. Ideally, it should be normal saline, which often is not available in your clinic. But what you should not use is a tear substitute which contains CMC, because that acts like the mucin, coats the surface of the cell, and subtle findings can be lost. Where do we put it? For fluorescein, we typically put it in the lower palpebral conch, like we just saw. But if you have a dry eye, and if you're using a lissamine and rose bengal, or one of the two, and if you think there's not enough tears to take it across the surface, another way is to take it on the strip and then put it in the superior bulbar conjunctiva. So gravity will help it spread over the entire surface, and you can get better staining characteristics. A minor but important issue is that all of these dyes can stain the periocular tissues, and therefore you want to be careful, otherwise the patient may not be happy. So if we look at fluorescein, if you have very little fluorescein in the tear film, you don't get adequate fluorescence. As the concentration increases, so does the fluorescence. But paradoxically, when you exceed a certain amount of concentration, the fluorescence again decreases, and this is the phenomenon of quenching. So the sweet spot for maximum fluorescence is when you have this mid-range, neither too little, not too much. And that sweet spot is when you have a 0.1 to 0.2% for ideal fluorescence. And that is why you want to use a small amount of 1 microliter of 2% fluorescein. The tears contain about 10 microliter, so the dilution would give you the ideal concentration of 0.2%. Remember that the conjunctival cul-de-sac is only about 7 to 10 microliters, whereas one drop is about 30 to 50. So it's many times the volume of the cul-de-sac. And the normal tear volume, which dilutes the fluorescein, is also about 7 to 10 microliters. I'll just show you an example in my clinic assistant who has a normal ocular surface. So in this first video, I take a drop of diluent on the fluorescein strip and I put the entire drop into the eye. So you can see the quantum that's going in, and when he blinks, you can see the overspill. So too much fluorescein. The other way is what Professor Yokoi showed. You take the diluent on the strip, shake it off nicely, and gently just touch the palpebral surface, and this is all you need. So what happens when we do these two methods? You can see the fluorescence in the first method in the tear meniscus, but you can also see a lot of fluorescein in the tear film. And it's not difficult to imagine that if you had subtle staining on the corneal surface, this fluorescence in the tear film would hide it or mask it. On the other hand, when I use that 1 to 2 microliters, you see the adequate fluorescence. So that's enough to give you the fluorescence. But you can see the tear meniscus does not contain enough fluorescein to hide corneal findings. This is a normal surface, so there are no findings. But if we had fine punctate staining, the right picture would be a better way to detect it than the one on the left. So how do we look at this staining? When do we look at it? Basically, for fluorescein, you want to look at it somewhere between 0 and 1 minute, or ideally within 2 minutes. We all use the excitation blue filter, but as I'll show you, if you can use an yellow filter, this will enhance your ability to pick up the staining. For rose bengal and lissamine green, white light is good enough. So the technique to do this is to gently pull up the upper lid to look at the static staining that I'm talking about, because many important findings may be present in the superior cornea or the superior limbal conjunctiva. So what I'm talking about is the static use of the static staining with fluorescein, and what Professor Yokoi showed you was the dynamic use of fluorescein staining. So what exactly are we doing? We know that when we instill light into the eye with fluorescein on the surface, fluorescein absorbs light at 465 to 490 nanometers, and therefore we use an excitation filter so that the correct wavelength of light can be used to stimulate the fluorescein. The stimulated fluorescein emits fluorescence, and when you see the fluorescence, which is mixed with the blue light as well, and therefore it is a little muted. If you can use a yellow rattan barrier filter, which knocks off the light below 510 so that the blue light can be blocked, you can appreciate the fluorescence a lot better. Show you examples of this acanthamoeba keratitis, plain, blue, and yellow light. This is a DALK patient with a HSV keratitis who is recovering. This is you can see the comparison once the yellow filter is on for the fluorescence. I will be frank with you though, if you have a good slit lamp and a good barrier and barrier filter, basically you can find where the yellow filter actually comes into its own is when you use fluorescein to look at staining. Normally, when you use fluorescein and look at the conjunctiva, you see nothing in the blue light because of the intense reflection from the sclera. So the bottom picture is with the yellow filter, fluorescein staining of the conjunctiva, and on the top is the same eye, the same conjunctiva stained with lissamine green, and you can see that both are equivalent. So if you have a good yellow filter, in addition to your blue filter, you don't need the lissamine and the rose bengal. Fluorescein alone is enough to look at the entire corneal surface. For those of us who don't have the yellow filter in our slit lamps, you can find these on the internet, and they're actually cheaper than this as well now. You have to hold this filter in front of the objective of your slit lamp so that when the light comes back from the patient's eye, the blue light can get filtered off and you can see the fluorescence better. The other thing was about the timing. We talked about that 0 to 1 minute or so. That is because initially, if you instill a little excess dye in the tear film, it blocks your findings. And if you wait for a minute or so, the excess dye goes away and then you can pick up the staining better. On the other hand, in a very dry eye, when you put the fluorescein, it takes some time for the lack of tears to dilute the fluorescein. And initially it's dark and quenched, but with time, you can see the staining. However, the 2-minute guide is important because if you wait too long, the fluorescein breaks through the abnormal epithelium. And as I told you before, it tends to diffuse. And at 10 minutes appearance like this changes the morphology of the staining that you see, and it's hard to make a diagnosis. This timing is not so relevant with rose bengal and lissamine because they do take some time to stain. So you want to wait up to 2 minutes, but they don't diffuse. So even if you wait a little longer, is all right. The other point you must remember is about pooling versus staining. This is somebody with a Murans that I had been treating who came back with symptoms. So when I put the dye, it looked like the entire ulcer had reactivated. But remember, there's already a gutter from his past Murans. So if you put in a couple of drops of some fluid to wash away the surface, you can see that what is actually happening is the small area of reactivation. The rest of the initial pooling was in the gutter that was already there. So remember pooling versus staining. So where do we look for this? Basically, the first grading scale that was used was the Van Bijsterveldt score. When he used rose bengal to stain the entire ocular surface, he divided it to 3 parts, and each of these he scored semi-quantitatively from 0 to 3 for a score of 9. The next is the OSS, or the ocular staining score, from the Jogren's Alliance. So here, in order to give equal weightage to the cornea, they added another 3 points to the cornea, one for the presence of confluence staining on the cornea, one for staining in the pupillary area, and one for the presence of filaments. So this became a total score of 12, 6 for the cornea and 6 for the conjunctiva. Then came bronze Oxford grading scale, where you have a series of photographic plates that you put up next to your slit lamp, and then you compare your patient staining with this to grade them from 0 to 5. And there are yet many more patterns of staining or grading. So this basically looks at the density of staining. For practical purposes, while we do need some kind of a scaling score, it may not be possible to go into that much of detail where they actually can count the number of staining spots. So what I like to do is I like to divide the ocular surface into 3 parts, but then I also like to divide the cornea into 3 parts. So it's basically 15, 3, 9, and 3. The reason I do this is because it's not just the amount of staining on the cornea that is important, but also the area of staining, which gives you important clues. Apart from this, you also want to look at the lid wiper and the upper lid and the lid margin in the lower lid. So the reason why I said that the area of staining is important is because if you see staining only in the inferior 1/3 of the cornea, this often depicts lid margin disease, because most of the toxic stuff from the meibomian glands and the blepharitis tends to pool in the tear meniscus, and the adjacent cornea gets affected. Similarly, if you see changes mostly in the upper 1/3 of the cornea, this is from the upper eyelid, typically some allergic phenomenon. And if it's in the interpalpebral exposed area of the cornea, it's some kind of dryness with desiccation and evaporation. If you see this staining, but the upper 1/3 is upper 1 to 2 millimeters is also stained, then it means either it's a very severe dry eye, or if you don't see equivalent conjunctival staining, it means there is toxicity from the medicine or the preservative, because this enters the tear film, goes under the lid, and the protection of the lid is lost. You also want to look at the superior limbal conjunctiva for SLKC and the inferior bulbar conjunctiva for conjunctivochalasis related damage. The lid viper is this 2 to 3 millimeters in this flipped upper lid, distalmost part of the mucosa, which is the pad that contacts the ocular surface, and this will stain in lid viper epitheliopathy. And the rose Bengal staining of the lower lid margin is the line of marks. Normally, it is present at the opening of the meibomian glands, but as in this dry eye, as the meniscus decreases and shrinks, this line will move more and more posteriorly towards the posterior lid margin. So essentially, these are the questions that we asked. So we can use fluorescein staining for important information about the ocular surface, but to do that, we must first understand the basis of ocular surface staining. What is it that we are seeing? What does it represent? We must understand the dyes that we are using and their appropriate use, including the proper diluent and the timing of the examination. Use the appropriate examination technique, including the proper filters, and have some system of scoring or categorizing these changes so it helps you to follow up the patient sequentially. And as I said, if you have a yellow filter, then fluorescein is sufficient to look at the conjunctiva. But if you don't have one and want to use either of the other 2 dyes, today lissamine green is preferred over rose Bengal because of the properties that I mentioned. Thank you very much for your patient hearing.